Hello everybody, my name is Martin Thaler and unfortunately I cannot be in Houston. We all know the reason, it's COVID, the excuse for everything in the last 2 years. But nowadays traveling is still restricted due to COVID, so I apologize for not being in Houston. But I thank you very much for the invitation and the possibility to speak about femur, osteoporosis and elderly patients. I hope I can see you all again next year at the ICGR in Houston. Osteoporosis is bone alterations in metabolic bone disease, and that is a major pivotal clinical problem. The major metabolic bone lesions are related to bone demineralization. There are different stages of it. First of all, osteopenia, that's a bone mineral density reduction. Followed by osteoporosis, which means that bone mass is abnormally low with increased fracture risk. Then there is osteomalacia. That means a softening of the bone, defective bone mineralization. And the last stage is osteonecrosis, which is bone death, caused by poor blood supply. Osteoporosis is a systematic skeletal disease characterized by low bone mass, microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. It can be divided into primary osteoporosis, into type 1, which means postmenopausal, and type 2, which means senile, and secondary osteoporosis, which can be a consequence of a lot of diseases and causes which you see below. Osteoporosis can cause severe potential complications in total hip arthroplasty, like it has an increased risk for intraoperative fracture, increased risk of periprosthetic fracture after the surgery. It can cause delayed osteointegration of the stem, periprosthetic osteolysis with loosening, and cementless implants are not always the best choice and are developed for good bone quality and not for patients with osteoporosis. Approximately 1/3 of all women over 50 years suffer from osteoporosis. 20% of men over 50 years suffer from osteoporosis, and 15 to 30% of men and 30 to 50% of women suffer from fractures related to osteoporosis in their life. In women, it is 3 times more common than men to have a fracture because they live longer, have hormonal changes, and a low peak bone mass. In 2010, 22 million women and 5.5 million men were estimated to have osteoporosis in Europe. Is there a correlation between osteoarthritis and osteoporosis? And that was first investigated in 1972. And osteoarthritis is rarely highlighted in patients with a femoral fracture. And patients with osteoarthritis of the hip have a reduced risk of fracture. So osteoporosis and osteoarthritis are different diseases that can coexist in patients with over the age of 75 years old. Of course, when we think about osteoporosis, we have also to think about intraoperative periprosthetic fracture. And we all know that the rate of intraoperative periprosthetic fractures is higher than estimated. So it is reported in literature. Of course, I know that everybody in the audience has lower percentages, but in primary it's reported between 1 and 1.7%. With cemented stems, it's drastically lower, between 0.3 and 1.7%, where in uncemented stems it varies between 3 and 5.4%. And when we look at the revision total hip arthroplasty, we see that in revision cases it's even higher. It's approximately 8%, with cemented stems 3%, and with uncemented stems approximately 20% of all revision cases. And it's becoming more common because intraoperative periprosthetic fractures are becoming more common because we are more and more performing revision total hip arthroplasty, and more implants are fixed without cement, cementless. But it's good to know if we have intraoperative periprosthetic fracture, it does not compromise our long-term results if we treat that appropriate and reach during the OR to a stable fixation of the implant. What are the risk factors for an intraoperative periprosthetic fracture? Risk factors are when we use cementless stems, have a low ratio between cortical and canal diameter, when we underream the femoral canal, and we use a large diameter stem. Other risk factors are an increased age, over 75 years old, revision operations, if the patients are female, or the patients have a metabolic bone disease, or altered morphology like Paget disease, and if technical errors at the time of the operation occur. And of course, the experience of the surgeon is related to the ratio of intraoperative periprosthetic fractures. So when we talk about total hip arthroplasty in elderly, we know that cementless stems have more complication. And cemented stems have less costs. Why? Because they are cheaper as an implant and cause less complications. So the recommendation I have for my residents and for all surgeons who ask me is, if a patient is more than 75 years old, we use an uncemented stem and an uncemented cup, and in most cases a dual mobility cup, so a hybrid solution for the patient, because we all know that causes low complications. When we look at hemiarthroplasty, it's even worse. So the risk factors of implant failure in hemiarthroplasties are known that over 55 years there's a significant increased risk of periprosthetic fracture in the first month after surgery. If patients are more than 65 years old, we know that there's a significant increased risk of periprosthetic fracture in the first 3 months after surgery. And if patients have an ASA score from 3 to 4, we have increased failure rate of uncemented stems, and a BMI more than 30, increased risk of failure of uncemented stems. So also here everything speaks for the use of a cemented stem. But now you will say for sure that how dangerous is cement? And it's really threatening because the overall incidence of bone cement implantation syndrome, which means that there is something caused by cement during surgery, is approximately 28%. But the risk of embolism and there's a low incidence of clinically relevant consequences, and you can risk, for example, embolism if you use a jet lavage and an adequate cementing technique, which we are still able to do in Europe. So the indication for cemented stems are a patient which is older than 75 years old, a ASA score between 3 or 4, coincidence of comorbidities, BMI more than 30, neurologic disorders or psychiatric disorders, or if you're not sure if you should use one or not use one, rather use one. So again, we recommend in the elderly to address osteoporosis in patients who are above 75 years old, a cemented stem and uncemented cups, and we choose here also a dual mobility cup to reduce the risk of dislocation. Thank you very much. I hope you have a nice meeting in Houston.